So hello and welcome to the Q&A session on diffuse large B-cell lymphoma and other aggressive lymphoma. My name is Rumana Khouri, and I'm the National Director of Fund Development at Lymphoma Canada. I'll be the facilitator of this session today. I'm pleased to welcome here Dr. Anka Prika, who is a staff hematologist at Princess Margaret Cancer Center and associate professor in the Division of Hematology at the University of Toronto. She will be answering your questions from the breakout session on diffuse large B-cell lymphoma and also known as DLBCL. As a reminder to our audience members, please type your question into the Q&A chat box, which can be found in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. Thank you.
So I guess I'll start. So thank you very much, everyone, for joining. I'm Anka Prika. I'm a lymphoma physician at Princess Margaret, and hopefully you had a chance to listen to the pre-recorded session, trying to highlight some diagnostic and treatment options in aggressive B-cell lymphoma. So we've had some questions. So I think I'll start with those. I'll sort of summarize what the question is about and try to answer it. So the first one is a younger patient, someone that's 39, who was diagnosed with something called nodular lymphocyte predominant Hodgkin lymphoma in 2023. It was early stage, but then progressed to more advanced stage, and they were treated with R-CHOP chemotherapy with a remission. About 6 months later, it came back, quite widespread, and a biopsy confirmed transformation to T-cell-rich, histiocyte-rich DLBC, diffuse large B-cell lymphoma. They're undergoing salvage chemotherapy with a recipe called RICE with a plan for autologous stem cell transplantation. So the question is, based on the current treatment, what is the prognosis after completing therapy? What is the expected life expectancy following an autologous stem cell transplant for this situation? And if the disease was to relapse again, what treatment options might be available next? So this is an interesting question. It's sort of a rarer subtype of diffuse large B-cell lymphoma. I didn't address in detail in the talk. But there are some indolent lymphomas, more commonly indolent B-cell lymphomas that can transform to more aggressive lymphoma. But this particular subtype that for many years is more under the Hodgkin lymphoma category, but probably somewhere in between, can transform to this particular subtype T-cell histiocyte-rich DLBCL. And then when this relapses after chemotherapy, although in the second line, after primary therapy, although in the second line setting, now we're using more CAR T-cell therapy for most DLBCL patients, the data in this particular subtype is a little bit less favorable. So I think it's very reasonable to take this approach. And actually, when we look at some data from large bone marrow transplant registries, this subtype does quite well so if you respond and make it to an autologous stem cell transplant, you have a very good chance, probably more than 3/4 of staying in remission for the longer term and living 5 years plus and more on average. So that could do quite well. If we were to relapse again, some of the options I described, like CAR T-cell therapy and bispecific antibodies, could be considered, although the data in this subtype is a little bit, the responses and the outcomes were maybe not quite as good as the overall diffuse large B-cell lymphoma group, but would still be something to consider and would be discussed with your physician. So moving on to the next question, there's a question around someone that had a bone fracture and surgery in the humerus, and no cancer was found at the time. Then there was a second pathological fracture And there was a wait of 6 months before a second surgery could be done. But at that time, on the surgical biopsy, there was diffuse large B-cell lymphoma found. And the disease was only in the right humerus, so sort of the upper arm bone, stage 1E. And blood work is okay. Originally this was described as Paget's disease of the bone. So the question is this related to Paget's? Is it possible I don't have Paget's and it's been DLBCL all this time? And you've asked your oncology team and orthopedic surgeon, and no one knows the answer to either of these questions. So I'm not sure I'll be able to give you the perfect answer here. And so that is a very good question. So we see a fair bit of primary bone lymphoma here because we're associated with a center that also does a lot of sarcoma, and the orthopedic surgeons there will see patients that sometimes end up having lymphoma. I don't know that from the literature and our look at our data, Paget's disease was a known association, although the metabolic bone disease is getting a little bit away from me in terms of my internal medicine days, but I'm not sure that it would be related to Paget's, and I do wonder if it's possible that it wasn't Paget's disease and potentially DLBCL. Although usually DLBCL, even though it can grow a little bit slower, I wouldn't think. I guess it sounds like this has been going on for about 8 or 9 months, so maybe a little bit long, but it would be possible. Again, I'd have to go refresh a little bit my memory on how Paget's disease is usually diagnosed and followed. But in my experience, again, having seen a number of people with this primary bone lymphoma problem over time, this wasn't an association that I'm aware of. So hopefully that answered the question. If, of course, if I say anything and you want some follow-up clarification, please type it in and I'll go back to these answers. The next question is, what are the recurrence statistics for DLBCL double hit lymphoma? The person had dose-adjusted R-EPOCH-R treatment and is currently 2.5 years in remission. So you're right, or that is a good question. We generally think of double hit diffuse large B-cell lymphoma as poor, higher risk in terms of the chances of putting it in long-term remission with primary therapy, but that chance is not zero. So it's probably more in the kind of 40 to 50% range, perhaps a little bit under 40%. We think about it like how many people are still in remission at 2 years, for example, from the time they had primary therapy, and those would be kind of the statistics, which are lower than what we see with in people who don't have this problem, where it might be 60 or 70% or higher. But again, there is a proportion of patients who can do quite well and have a longer term remission. And usually if you get past the 2.5 year mark, the chances of coming back are maybe considered quite a bit lower, just like we say for all diffuse large B-cell lymphoma. So hopefully that gives you some answer that some of the statistics we have are from people that were the higher risk patients, that some of the testing has changed over time. So perhaps it's just prognosis of patients who looked high risk from the beginning, but there is a proportion of patients who can do quite well. And I certainly have patients in my practice with the double hit lymphoma treated with dose-adjusted R-EPOCH-R who are still in remission several years later.
The next question, the next question that we received is, if an indolent lymphoma transforms to aggressive DLBCL and is treated, is the indolent form also treated?
So that's a very good question. So most of the chemotherapies we use, particularly if there's a transformation to aggressive diffuse large B-cell lymphoma, we would use R-CHOP chemotherapy frontline most of the time. And so that is a chemotherapy that also treats indolent lymphoma, definitely. So as would most chemotherapy recipes that we use to sort of and usually would induce a remission, kind of how long and the prognosis from that perspective. There is some data or there is evidence out there that it could be for numerous years. And so, yeah, so the answer would be that both the aggressive and the indolent component get treated.
Thank you. Thank you for clarifying. So the next question is, what is recommended treatment should lymphoma double hit reoccur?
So that's a very good question. The kind of options for treatment are fairly similar to what, or the same as what would be for all diffuse large B-cell lymphoma, which is that if the lymphoma recurs within a year of finishing therapy, really the recommended treatment is CAR T-cell therapy. And there are a couple products that are available, as we discussed. Unfortunately, probably the larger proportion of lymphomas and double hit lymphoma, but all diffuse large B-cell lymphomas in general recur within that first year. If it's longer than that, the approach is still more kind of traditional, giving some salvage chemotherapy and trying to have an autologous stem cell transplant. And these would be in patients who, or in people who are considered transplant eligible or kind of fit for these therapies. If it was someone older or more comorbidities, there'd be other treatment options that would be discussed.
Thank you. And I see another question coming. It's I'm 2 years post CAR T for double hit lymphoma. Now with an indolent lymphoma, what impact would CAR T, if any, have on the indolent lymphoma? I'm currently on a wait and watch.
Excellent question. Probably a more unique scenario. So, and I'm not sure if you had the indolent lymphoma known before, or this is a new diagnosis of an indolent lymphoma or newly kind of identified. I mean, certainly all CAR T products we have work very well in indolent lymphomas as well. So certainly if it was there before, you would have hoped it kind of treated it as well. Now, you know, I don't believe there's strong data to suggest that there's a risk of other lymphomas post CAR T-cell therapy, at least not B-cell lymphomas. There's a small risk of some other cancers that are monitored, but not lymphoma. So I don't know that I would think that it was related to the CAR T-cell therapy, whether the CAR T was still exerting an effect on the indolent lymphoma in terms of the natural history. It's possible. I think it's very reasonable if, of course, not knowing all the circumstances, to take an observation approach, and if it needed treatment, probably I would imagine not or at least the way the data and the funding is, that other treatment options would be considered at that time.
The next question is, I have been clear of DLBCL for almost 6 years. However, I'm told I still have follicular lymphoma. Does that mean I have a higher risk of relapse? Also, what percentage of DLBCL patients also have follicular lymphoma?
Excellent questions. Again, I'm not, without knowing the details as to whether the follicular lymphoma kind of coexisted or was there from before, or this was a new diagnosis, I would perhaps refine that question. But probably most of the time, I would think that they were related diagnoses, and perhaps the follicular lymphoma had been there all along or for a while, and really, we only know the diagnosis that is picked up on a biopsy at the time that there's a clinical presentation, and if it was something that grew faster, that would be more likely to be the diffuse large B-cell lymphoma. Usually, if it has been 6 years, we do think that the DLBCL component has been cured, and I don't necessarily think that component would have a high risk of relapsing. However, follicular lymphoma there is always a small risk of transformation a couple percentages a year when people are living with follicular lymphoma. So maybe a different kind of clone of that could transform to aggressive lymphoma, but that risk would be kind of similar to, I think, what we would usually say for all follicular lymphoma patients. And in terms of you're testing my epidemiology and knowledge, what percentage of DLBCL patients also have follicular lymphoma? There is a significant overlap, and I'm going to dig deep to say that it's at least probably 20-30% of patients that have both. And that's, again, just from our ability to pick that up on biopsies, but it is quite common, and it is quite common to see people that live with follicular lymphoma for a while and then have a transformation to diffuse large B-cell lymphoma.
The next question is, my husband was diagnosed with a triple hit DLBCL in December 24. He had 2 rounds of R-CHOP, 1 of EPOCH, 8 rounds of radiation, bridging chemo before CAR-T, April 2025. If the CAR-T fails, what options are available for him? He is 50 years old.
Yes, so I'm sorry to hear the challenging disease course he's had in the last few months, and certainly a tougher situation without knowing all the. There are perhaps some other prognostic factors that you think about the chances of that happening. But when we think about treatment options, it would be there are several. There would be the option to consider a bispecific antibody that I talked about in the talk. So the 2 that are funded in Ontario and in Canada are epcoritamab and glofitamab. There is the combination of kind of chemotherapy with polatuzumab. So polatuzumab, bendamustine, and rituximab could be an option to try. We may consider more radiation, and there may be some other medications to consider. And of course, and we always and encourage all of you, if you're in a situation where there is another treatment required, to ask about clinical trials that may be available in this setting, as we would consider what other clinical trials could be an option. There are there's newer CAR T cells being done, being tested and manufactured, trying to make what's available better, with targeting more targets and different ways of making them stronger. So there may be clinical trials with that, or with other targeted agents, or different options to try. So those would be the things to consider and to discuss with his physician what might be the best option for him.
Thank you. The next question we have is, how common are lymphoma subtypes transformation, and are there particular subtypes or risk factors that make it more likely?
Yeah, so good questions. Certainly all indolent lymphomas, and there are some that are more common. The most common indolent lymphoma is follicular lymphoma, and there are subtypes like marginal zone lymphoma, Waldenstrom's, even CLL, chronic lymphocytic leukemia, or small lymphocytic lymphoma, all have a chance or a risk of transforming to an aggressive B-cell lymphoma. The only subtype that I would say does not transform to DLBCL is mantle cell lymphoma. Mantle cell lymphoma is kind of in between indolent and aggressive, and its own subtype that if it behaves more badly, is just because it's acquired its own risks for doing so. So there are some more common. So follicular lymphoma is the most common that transforms, and that's usually say it's about 3% per year risk of transformation, and that's kind of cumulative. So over 10 years, there would be a 30% risk of transforming from follicular to diffuse large B-cell lymphoma. Some of the other subtypes are much much more rare, like marginal zone, Waldenstrom's. They can happen, but but it would be a more rare event. And are there risk factors? Not really. Not that we know well in terms of predicting that risk. That's ongoing work that colleagues and scientists are working on to try to figure out, can you identify in advance why, when that might happen and who's more likely to do so, but we don't really have any good way of predicting it at this time.
The next question, I had marginal zone morphing into DI B cell treated with Bendrixtus, which drove it down but failed. Then B cell, B large B cell was found and R-CHOP failed. Now, then like the medicine, I would appreciate your help with like finding the name for this medicine. Has managed symptoms 4 months. How long can I expect that to last?
Right. So the question was around zanubrutinib, which is a targeted agent called part of the BTK inhibitor class. So certainly you've had the kind of most active and the treatments we would usually try in marginal zone lymphoma. So the bendamustine rituximab, the R-CHOP, and now the zanubrutinib. I guess without knowing quite the details, I would say that we always would want to know, to check, is this still transformation to diffuse large B-cell lymphoma versus the marginal zone lymphoma that's kind of causing the symptoms, because the treatment pathways are a little bit different. But if zanubrutinib is working, probably will work for some time. On average, it's not years of use. Of course, average means what happens to 50% of the people. So there's always some that can have a much longer response, and some that would be less than that. But I would expect that probably, without again knowing all the details, it might not last for a long time, but may last for a year or plus or some time like that. I will say, as I think I talked about in my talk, that there are other therapies, particularly CAR T-cell therapy, for those that are eligible and fit, is available for certainly for diffuse large B-cell lymphoma, that even if it's those that have transformed from other indolent lymphomas like marginal zone, but also for marginal zone lymphoma for people like you who've had a number of lines of therapy and still living with the disease. So that is something you could consider or talk to your doctor about if it would be appropriate for you.
Thank you for answering this question. The next question, if a patient experiences relapse or progression after CAR T therapy, are biospecific antibodies available as a treatment option afterwards?
Yes, so they are funded and available for this scenario. Whether they're the kind of best option for a patient is dependent on a few factors. Particularly, we know that if the progression happens very soon after CAR T-cell therapy, within 3 months of it, bispecifics are much less efficacious. But unfortunately, in that setting, not a lot of things are as helpful as we'd like them to be. And the other is that sometimes when the lymphomas there's been quite a bit of treatment, including drugs like rituximab, the marker of CD20 that's on the cells may disappear. And in that case, bispecifics are not as helpful or don't work very well. So your doctor, if this was the scenario, that would be a reason. We often say we'd like to biopsy again to see what's going on. And some might wonder, like, we already know it's DLBCL, why biopsy again? But there are things that can change that can really sort of adjust our therapy. So if there is no CD20 marker on the biopsy when the lymphoma came back, that would be a reason to maybe not consider bispecifics. And also sometimes as has been highlighted in some of the questions today, people can have both indolent and aggressive lymphomas. So we'd want to look on a biopsy if it was the aggressive component or the indolent that's coming back, because again, the treatment options may be different.
So the next question is, there are a few CAR T products available. How is it decided which is the best fit for patients?
So that's also a good question. It's probably a combination of factors that may be somewhat there are some common themes and that may be individualized to the patient. So the products can have a little bit of different or they do have some different toxicity profiles. The product Tisocel and Lysocel have less toxicity than for example, Axicel. But some of the efficacy may look a bit different for different scenarios, especially when we looked at Axicel, it looked perhaps like it controls or treats lymphoma a little bit better than Tisocel. So we were preferentially using that product. But now Lysocel has been funded in Canada or in provinces for a few months. And that's also a good product to consider. There are some other factors, such as some of the timelines of how long it takes to manufacture are a little bit different. So it kind of depends on the pace of the disease, the person's age, comorbidities, and other factors that we would put together to pick the best product for them.
Great, thanks. For patients with high-risk features, such as double hit or triple hit lymphoma, how does your initial approach differ?
Yes, so I think I talked about it a little bit, and it's been highlighted in some of the questions we've had today. We know that having this double hit or triple hit feature portends a higher risk in terms of really what we're looking at, the chance of putting the lymphoma in remission and not having it come back. And what is that chance, let's say at 2 years or 5 years? And that risk is, or that chance is lower than we'd like it to be with double hit lymphoma with R-CHOP chemotherapy. So there's been different attempts to kind of make that better over time. And one of them is to intensify chemotherapy with a recipe such as dose-adjusted or EPOC, which was mentioned in one of the questions, which is very similar drugs. It's just given a little bit more and more infusion also over 5 days. So the data, it's not a home run, unfortunately. So using that recipe doesn't make that risk go away completely, but in the literature seems to make that risk a little bit lower, or make the chances a little bit better of coming back, not coming back. So it is our preferred approach still for those that we think would be eligible and fit enough for it. But I would say some of the field is moving into, and it's not standard of care yet, but trying to use some of these novel therapies, let's say in frontline, to try to overcome that risk better. And there are ongoing trials putting CAR T-cell therapy into frontline or bispecifics into frontline. So perhaps that will be a better answer to improving outcomes for double hit lymphoma patients and high risk diffuse large B-cell lymphoma patients in general.
Yes. Next question is, when monitoring a patient in remission from both follicular and diffuse large B-cell, which lymphoma are they watching for? Just DLBCL or follicular or both? Also, is persistent fatigue common even years after achieving remission?
So yes, when we're monitoring, I would say the answer really is we're monitoring for both. We hope that we've cured the diffuse large B-cell lymphoma component and it won't come back, but we monitor for that. And we think that for the majority of people, if they live long enough, follicular lymphoma at some point may grow back, although again, it's definitely not in everyone, and we're talking about averages in terms of numbers. So we're monitoring for both. The monitoring approach is fairly similar in terms of what we're looking for in terms of symptoms, kind of changes in symptoms, blood work, although I'd say blood work is probably less helpful in lymphoma, and it's more about how people feel, but we're watching for both. Fatigue is a very challenging symptom, because of course there can be many reasons or that people can be fatigued, and that can change over time. So, but that being said, I would say it's not uncommon for me to see in my practice people describing ongoing fatigue years after treatment, and whether that's kind of a change in the baseline compared to how things were before chemotherapy and before treatment. Or there can be, we intermittently do check for reversible issues, like, looking for thyroid tests or B12, vitamin D deficiency, things like that. But if there's really nothing identifiable and there's not another reason, I think there could be still some kind of lingering fatigue that's just perhaps a new baseline, unfortunately, for some.
Thank you. Are there scenarios where you would consider adding targeted agent to standard chemoimmunotherapy in the first line?
So I mean, I described a bit the data with adding the polatuzumab, which is an antibody drug conjugate, so targeted but still kind of chemotherapy, or just bringing the chemotherapy right to the cell, to the lymphoma cancer cells. So so there is the data with adding that in a recipe called Pola-R-CHP, particularly in one of the subtypes of diffuse large B-cell lymphoma called activated B-cell type, or a version of that. And in some of those scenarios, it's improved some of the outcomes. And it's not quite available for funding publicly in Canada, but probably will be for that subtype soon, or sometimes we can explore it through other avenues if available.
Yeah. Thank you so much for this explanation and answering the questions. So to conclude this session, I would like to thank Dr. Anka Aprika for taking the time to participate in today's Q&A. We hope those watching today learned something new about their and their loved ones' lymphoma subtype. If you have any more questions, Lymphoma Canada will be hosting a separate Q&A on October 30th as part of our Ask a Specialist Lymphoma CLL Specialist Q&A program, where patients can submit their questions in advance and register for the live webinar to hear answers directly from our experts. For more information and to submit your question or register, visit our website, www.lymphoma.ca. With this said, please tune into the next session titled Accessing Clinical Trial in Canada, which will be starting shortly. Thank you so much. Bye.